What can you eat?
Whatever I eat, I had to swallow. I chew really good. Chew, 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 chew. Milkshakes are good. Power drinks.
Okay.
He's drinking Boost, Ensure, that kind of stuff, and then I bought some stuff at the GNC store that has the creatine,
Okay.
creatine, creatine, I don't know how to say it,
Mm-hmm.
but they're to keep up the muscle tone and all that.
Okay.
And we're doing those a couple of times a day. If I cook something that's like mashed potatoes and gravy or peas, he can get some of that kind of stuff down.
Okay.
Spaghetti, soft, really soft food.
Yeah, really well-cooked pastas are usually really good with some of the cream sauce in terms of calorie.
Okay.
But what I'm thinking is actually, like, say, in terms of the big picture of where things are. So what you have is actually something very common. We see actually quite a few of them. It has changed a lot. So in the past,
the base of town.
Base of town, yeah. So it's quite common, and oropharynx is one of the more common sites that we treat in terms of at the back of the mouth, sort of from where your oral cavity in the front and basically go to the back of it. It has changed a lot. I think about 20 years ago, it used to be people who smoke a lot, drink a lot. It's a completely different type of cancer, and now they are P16 positive. What it actually means is that it's caused by a virus, the same virus that causes cervical cancer in women. So we find that with chemotherapy and radiation together, they work very well in terms of actually curing the cancer itself. So you're looking into 85–90% of cure rate. However, the treatment is very toxic. It takes a lot of effort in what we do, because we know you're going to do well. Ultimately, you're looking into 7–8 weeks of treatment itself every day. Like I said, the cure rate is great, so that's why we're pursuing to something like that. Alternatively is to do surgery. Surgery itself, of course, is a big surgery. I have seen it done before. Depending on where you are, there people have done it. What they would do, they would split the bone in half, open it up.
Here?
In the jawbone, yeah. They would saw it in half with a little S curve that sort of go around the little chin, and then they would split it open, and they would pull the tongue out, and then take out where the base of the tongue, the back of it, take out a big chunk of it, and then they will also take out whatever that is involved in the back of the throat itself, including the epiglottis, sort of everything that's surrounding it. Mm-hmm. Then you have a huge opening in there. Then you need to reconstruct it to find tissue to fill up that space so that you can learn to swallow again. Where they usually get it is usually from your forearm, depending on if you're right hand dominant or left hand dominant. They would take out part of that muscle, put it back in, and then reconstruct that part. It takes about 6–8 weeks for it to heal, and then afterwards, you would need to relearn how to speak and relearn how to swallow. As I'm describing it, it's a huge surgery. That surgery itself is usually about 14 to 16 hours.
That's what Charlie was talking about doing.
That's what
But
the
it's gone too far now.
ENT was talking about too.
They were talking about that's one of the potential of how it used to be done. It's a very involved surgery, especially the surgery itself for someone like yourself who is actually very healthy and young, that I think you actually do well in terms of surgery itself. It's more about what happened afterwards, because surgery or chemotherapy radiation will give you a good cure rate. However, the relearning how to swallow, relearning how to speak, that actually is a very difficult thing. Mm-hmm. Because that's going to, you find right now your speech is not very clear. With the new tongue at the back, its sounds would be about the same. So that is not a great solution for most people. Plus the surgery itself is pretty major.
Yeah.
You need ICU.
That's 2 shifts in it.
So I mean, but that's some people is possible. My concern is that when you have difficulty speaking and articulating using your tongue, that means my concern is that the cancer has started grabbing into the tongue muscle, has invading into it. Because when cancer started in one place, they get smart and they learn to travel. Just like in your case, where it started at the back of the tongue, then it starts to spread to the lymph node itself. So it starts to get to that point, and it seems to me that it starts to go more anteriorly towards the tongue. So I would not wait for very, very long before the treatment starts. Just because you're already losing weight, And the longer we wait from something that is curable, potentially it might not be. In terms of how urgent it has to be, it didn't have to be today or next week, but I would say within the next month that you should actually start at some point. That would be the general in terms of the big picture how things are. In terms of the differences between proton and regular radiation, the outcome is very similar. So depending on if the tongue is actually involved or not, that might change in terms of what your percentages are. But either way, you're looking into, even if it starts invading into your tongue, you're looking into at least 75% cure rate, which is still really good. And if it's not invading into your tongue, you're looking into like the high 80s, 90s. So
10% don't make it, or
No, cure-wise, it would be
cure-wise
cured
means that it's
90%.
completely cured. That means in 5 years they have
Might
no
come back,
signs of cancer. Of course, yeah. That, in other words, there are about 10% that they might come back. That means we might need other ways to do it. If it comes back, depending on where it is. If it comes back locally, you can go for surgery. Or if it comes back somewhere else, say if it shows up in the lungs, that means your cancer cells has actually gotten so smart. Even whatever we do, we treat everything as locally here. Just like surgery, they just treat this part. Once the cancer cells learn to travel and hide somewhere else, there is no good ways of treating it, unfortunately. So depending on where it is, you just don't know at this point, and we have the benefit of doubt that everything is local. It starts off one place and give you the kitchen sink treatment that basically is the radiation, chemotherapy every day.
Well, now on the PET scan, that would show you if it was anywhere else at this time, right?
The PET scan will give you a better idea, however, depending on if the cancer cells are active, because PET scan based on sugar, assuming that cells that are actively dividing, they use sugar. So if at the time of the scan, the cancer cell are sleeping, just like say you take baby ultrasound, if the baby is sleeping, it's not moving, doesn't mean the baby is dead. Just that moment when you're there, it's not growing, it's not doing anything, so it might not detect it. Or if it's too small, the signal itself cannot detect it. So it doesn't mean that there's nothing, but at least less likely, you're right. So a PET scan is a good possibility of looking into that to make sure it hasn't gone anywhere else.
We did have that and we brought that.
Good. And then the MRI itself, in terms of a fine cut, 1 millimeter or 2 millimeter cut, sort of all over the neck itself, would give us a better idea to see if the cancer cells has grown into the tongue as well. So those would really...
That's not good if it's into the tongue, huh?
Of course, the less it is involved, the smaller the volume, the better off you are, just like any cancer. So they use 2 centimeter, more than 2, or more than 4 centimeter as dividing the T stage, how big the tumor is. So less than 2, 2 to 4, bigger than 4, and then the rest of it, T4, is depending on what it starts to invade.
Where were we at on mine?
They said T2, stage 3 on the lymph node, but T2.
My thought is that you probably would be stage 4A. So the head and neck cancer, the stage 1, 2, 3, and 4 is not the same as lung cancer 1, 2, 3, and 4.
So it's growing, right? It's moving.
So the T2, T3, what it is, so T2 means that it's 2 to 4 centimeters, and T3 is 3 centimeter or more. T4 means that they start invading into the muscles. And that's my concern, that when I'm hearing you speak, it sounds like you have some trouble doing that. So we'll examine you, get a better idea if it's involved or not. Or if it start invading even to other places, could start invading into the nerve, into the bones and other places. So you had the scan not very long ago. I don't think it has changed that much from beginning of March to now. It's less than a month.
We had it Monday.
You have what scan? The PET CT you mean? Mm-hmm. Right. But no, the CT scan, the one that I looked at before, that was about a month ago.
Yeah.
And honestly, if your cancer is growing so fast from the scan a month ago to now, I don't think we can actually do anything about it, because if it's growing so aggressively within a month. But clinically, you are about the same. I doubt it would have changed a lot, because your neck mass still look about the same, your speech, everything is about the same. So that's as stable as everything can be. So like I said, there are different things to sort of decide what stage it is. The changes of the management is not too much. So
what's next? What do we do?
So the next thing, basically, almost anywhere now you go, the recommendation would be concurrent chemotherapy and radiation.
Right.
So the chemotherapy can be given in different ways. You can give it every week as a lower dose every week. So basically intravenously, they give you the chemotherapy. You sit through there for a few hours. The chemotherapy goal is to actually sensitize the radiation, makes the radiation more effective. It's a low dose, so not a lot of side effects compared to a high dose every 3-week chemotherapy. They started off initially with a study, is that say most people get cured by about 75%. Adding chemotherapy is like, oh, maybe we can improve the cure rate, and we find that it's about 10% better with the chemotherapy. But the chemotherapy, because almost anybody that you go and see the medical oncologist, they give chemo every 3 weeks. So that's how it started off, a big dose every 3 weeks, and it seems to work. Then they find that it's like, oh, maybe we can actually make more sense since the goal is to sensitize the radiation. You're getting radiation every day. There was actually one study that someone gave chemotherapy every single day before and around the treatment time. Well, it's not very practical when it takes a few hours to do that.
Right.
Just the radiation and then chemotherapy. But it seems to make sense. Of course, in our society, that nobody really have that time and that luxury for that treatment. So basically, we do it once a week and sort of somewhere in between, and the dose is much lower so that you don't get as much side effects from the chemotherapy. Less nausea, less vomiting, so things are better. And then with the chemotherapy itself, so well tolerated. If you decided to go with the chemotherapy, you need to see a medical oncologist. They will talk to you about the side effects to make sure it is safe to give it to you. I think you are a good candidate. Major side effects, chemotherapy: nausea, vomiting, pins and needles in the hands and feet, and potentially could affect your hearing. All the fine nerves could be affected. So if you're doing the chemotherapy and radiation, regardless of where it is, you need to do a hearing test to make sure the hearing does not change too much. And the weekly chemotherapy, the benefit is that if you notice your hearing start to get worse, they can cut down on the dose of chemotherapy or stop it altogether. Because the benefit is about 10%. But if you give a little bit of it, maybe you get 3 or 4%, but at least you get to keep most of your hearing. Because once the hearing is gone, it's gone. So the weekly chemotherapy has that benefit too. Then the radiation is usually given every day, Monday to Friday, every single day. It takes about an hour. It takes longer to line you up, to measure everything correctly, then they turn the machine on. The machine itself may be about 10-15 minutes only for the treatment. You'll be wearing a mask. It's a see-through mask that basically quite tight on your face so that you cannot move.
Mm-hmm.
There's a little piece that you bite in so that your mouth and everything is very stable. Then there's a little headrest at the back, and then there's laser on either side that they would align every day so that we can reproduce it. The goal is to have the smallest margin possible, because at the back of the throat and everything else, there are important structures we want to preserve, including your brainstem, which is important for swallowing, for other nerve function, your spinal cord, your hearing on both sides, your eyes, and everything else sort of in that proximity. So there are 2 ways of giving radiation nowadays. One is IMRT, is intensity modulated radiotherapy. The other way is proton. So I'll talk to you briefly about what the differences are. IMRT is the intensity modulated, means that you give radiation from 5 to 7 different areas of the field that we try to treat. So say if we try to treat here, if we try to treat so say this is where we're trying to treat. I can sit here and you'll be in between.
All right.
So